everyone from India. This is Dr. Akshay Jain. I'm an endocrinologist in Vancouver, and with me I have Dr. DeFronzo, a name that needs no introduction. He is responsible for changing our understanding of pathophysiology of diabetes, and a very, very eminent name in diabetes. And today we are at the American Diabetes Association conference in San Francisco. Welcome, Dr. DeFronzo.
Thanks. It's great to be here. It's been an exciting meeting. Lots of interesting stuff, and still more to come.
Absolutely. And we'd love to get Dr. DeFronzo's opinion about two seminal studies that were presented today. So we'll start off by talking about the REWIND trial with dulaglutide, and what are your first takes on it?
Yeah, so REWIND is an interesting trial because it had about 60% of the people in the study who had not had a previous cardiovascular event. So we were very excited to see the results, because this maybe would allow us to move back earlier in the natural history of type 2 diabetes to treat people before they had an event, so primary prevention. I think the results are pretty much as I expected. The hazard ratio for the composite endpoint, MACE, was 0.88, and I would say it's in line with all of the other trials. I don't think it's a blockbuster or above and beyond what the other trials have said. I think the most important thing is it says that maybe we ought to be thinking about moving the drug up for cardiovascular indications earlier on. There's some results are a little bit unusual, and that is that the major effect was on stroke. MI was not significantly decreased, cardiovascular mortality. But I think people want to overinterpret these studies, because you have to look at the composite MACE endpoint. No study is designed to look at each individual endpoint. So I don't get too carried away that study X showed more effect on MI, study X on stroke. I think in general we've seen cardiovascular protection. So it makes you feel more comfortable that all of the long-acting GLP-1 receptor agonists. But I've said all along, you should be using these drugs now before for other reasons. Now we have cardiovascular. I mean, these drugs control your A1C and they keep it down. They preserve beta cell function. No hypoglycemia. They make you lose weight. And the safety profile is very good. And now, they keep you from dying. That's pretty good,
That's pretty good.
So I would say, why don't we use all of the, and I don't really care which one of the drugs you use. In my opinion, they should be first-line therapy.
Absolutely. And a very important point to note, of course, is that the enrollment A1C was not very high. It was 7.2% or so, right?
Yeah,
so,
which is a little bit surprising.
It is.
I want to know. I want to bring all my patients to these docs.
Exactly. Also very different about this study was that 46%, almost half of these patients were female, which is probably more representative of what we've seen in daily life with primary prevention.
Yeah, and as you said, in the previous clinical trials, 30% were females. Here it was 46%. Again, what it's saying is that it really doesn't make any difference whether it's guys or gals, whether you have overt diabetes with complications cardiovascular-wise or risk factors. And again, the annual incident rate is low, 2.7%. And I've said all along that if you wait and you carry out the study long enough, even in these less high-risk patients, you'll see a positive result. And here, the follow-up is 5.4 years.
It's pretty low.
So to me, it's not all that surprising if you have a large population, 9,000 people, and you go for 5.4 years, you'll bring up a small effect, okay? So to me, you have to look at the composite of why we use GLP-1 receptor agonists. And cardiovascular, of course, happens to be a very important one that goes along with A1C lowering, weight loss, beta cell protection, etc.
Absolutely. Just a question regarding the inclusion. A lot of our viewers are from India, and we noticed that in REWIND, India and China, which form probably 30% of the total diabetes burden in the world, these two countries were not included. But do you think that this could be applicable to all ethnicities?
Yeah, so I mean, one always would feel more comfortable if we had a more diverse ethnic group. But personally, I think that they would be applicable. But that's sort of a statement based on lack of evidence from this study. But if you look at other studies in general, we tend to see the same kind of effects in different populations. This is particularly germane to maybe the Indian population because they have an increased incidence of cardiovascular disease and also central obesity and insulin resistance. So I think it would have been nice if we had more of a, say, Far Eastern population and more of a, Pacific Indian population. But I think the results probably would be the same.
That's good to know. And then finally, with DECLARE, we had some newer data that was shown today as well. And any thoughts on what was presented with DECLARE?
Yeah, see, I think, we all know the results of DECLARE. They've been published in the New England Journal of Medicine. And the combined endpoint of hospitalization for heart failure and mortality was significantly reduced. The MACE endpoint did not reach statistical significance. But again, overall, when you look at the data together, there's cardiovascular protection. Mm-hmm. What's new and what we saw here is now the renal data, which are very impressive. So it didn't make any difference what your GFR was, whether you're going from a low GFR up to a high GFR, then you're seeing protection in terms of a composite endpoint, which is pretty serious. Doubling of your serum creatinine with a eGFR less than 40, going to end-stage renal disease, dialysis, etc. So wherever your GFR is, you're getting protection. The other thing that was nice is that if you look at albuminuria, we saw the same level, same kind of thing. Low albuminuria to high albuminuria.
It's the same.
Same.
Absolutely.
And the diagram where they plotted albuminuria versus
that was very impressive.
GFR, you can see there's a synergistic action going up. So I would say these results are very consistent with the Credence results. And to me, these drugs, these SGLT2 inhibitors, really should be, I think they're probably even going to turn out to be better than the ACEs and the ARBs, but they for sure should be using in combination in anyone who's at risk, meaning either they have a decrease in GFR or they got proteinuria.
Excellent. Thanks so much. Always so much to learn from Dr. DeFronzo, and thank you for your time.
Glad to be here, and I'm looking forward to my visit to India, which is coming up in November. So for all of you out there, I'll see you in about 3 or 4 months.
Great. Thank you.
Okay.